As we begin our discussion with the gram-positive bacilli, realize that none of the organisms that we're going to talk about in this unit are nearly as important as the gram-positive cocci, which we have left. But a convenient way of dividing these guys is to first of all ask which ones are spore formers and which ones are non-spore formers. From that point, dividing them into whether or not they are aerobic or anaerobic in each case becomes an easy way to categorize them. So remember, in the aerobic spore formers, we have bacillus. In the anaerobic spore formers, we have Clostridium. In the aerobic non-spore formers, we have Corynebacterium, which of course I'm not going to see unless I have an unvaccinated child. And then I have the facultative intracellulars, Listeria, Mycobacterium, and Nocardia, remembering that I'm handling Mycobacterium here in spite of the fact that it truly does not stain with the gram stain. And I described why I was doing that in a previous discussion. I want to do Mycobacterium while you're still alive, and in case you have died from overexposure by the time I get to the end of the chapter, then I will feel confident at least that you got what you needed before you succumbed to the intensity of this chapter. Of my anaerobic non-spore formers, I have Actinomyces and Lactobacillus. Propionibacterium, probably not a terribly important organism, but its name, Propionibacterium acne, tells us that it is a major contributor to those abscesses that I see in acne. Now, let's go back a moment to the spore formers and look at my commentary about motility, because I think it's an important lesson on how to categorize your knowledge by constantly asking yourself if you should care. I know I've made fun of that at several points during my discussions with you, but the fact is, if you cannot convince yourself of a reason why you should care about something, then I think you really should not waste your time memorizing it. You could argue that you would be much more entertaining at a cocktail party if you knew every fact in the world, but it's not going to make you a better doctor. And so, since that is our goal, that's what I want to emphasize here. Now notice, if I keep my eyes on the prize and ask myself constantly, what is the mechanism by which a given organism causes disease, then realize when I think about Bacillus anthracis, I'm remembering it's that 3-component toxin that causes the problems. It doesn't matter if Bacillus anthracis is capable of moving. It infects you via the inert spore, and once you're infected, it begins to make the toxin, which is what either kills you or doesn't. So the motility of that organism is really not important for how it contributes to disease. When I think about the anaerobes, remember that when we talk about Clostridium perfringens, one might think that it's an incredibly motile organism because of the fact that the disease process moves so rapidly throughout all of the tissues and the extracellular matrix. But remember, that's not what's causing the problem in that scenario. It's not the motility that is making the organism dangerous. It's the fact that it produces all of those tissue-dissolving enzymes. So it's killing you via toxin production, not via motility. So I mentioned it here purely to say to you, don't just make yourself flashcards with every single fact that exists on them. Think about everything that you put onto a flashcard. Is this important for me to know? Does it contribute to the disease I see? If it does, then obviously motility becomes important. But in general, I would argue that the motility of an organism is a lesser pathogenic feature except in one case, and that is in the case where I'm speaking about urinary tract infections. Remember, in that scenario, it's going to be important for the organism to be able to move against the flow of urine. So not only does the organism need to be adherent to the uroepithelium, but it also needs to be able to move. So of course, know that all of the UTI agents are modal. That means I'm memorizing one fact, one concept, one principle, instead of memorizing piles of discrete facts that I then have to try to remember. Microbiology becomes overwhelming if you don't truly ask yourself, should I care? All right, so now let's go on and talk about these individually, starting with our aerobic spore former, Bacillus. Realize this is widespread in nature, naturally found in animal hides and in the soil, because of the ability of the spore to withstand unpleasant environments. So transmission is either by inhalation or traumatic implantation of the spores. And then once the spores are in the body, it is the production of the toxin that becomes an issue. Of course, we have concern of this one as a potential biowarfare agent. Realize that the reason why that's true is because of the spore formation. If one wants to be a terrorist, and I'm certainly not advocating that, but realize from the point of view of the person who's trying to kill people, it would be true that if I can make a spore and then distribute it, I can have confidence that that spore will be waiting around until humans come to interact with it. So it is the spore that makes this organism a good potential bioweapon. And certainly it is on our screen as thinking about this in control mechanisms. Many of the other types of biowarfare potentials are on the list of weapons because of the fact that they're easily transmissible from person to person. Remember, anthrax, that's not the issue. It's transmissible from a point source in soil or animal hides, etc. Now, for Bacillus cereus, remember, this is my second type of foodborne disease that's associated with a very rapid onset. So buffet-style restaurants, what that clue implies is that the organism is being kept at a temperature where it survived the initial cooking and is now germinating as the temperature of the buffet restaurant is lowered and it can produce the toxin. So like Staph aureus, which is the other very rapid onset one, this is going to be a preformed toxin in the food. So speaking first of all about anthrax, remember I have two forms. So I could have a patient who had been exposed to hides or soil or leather that had a black skin ulcer. This is referred to as the anthrax S scar. And the disease, cutaneous anthrax, is a localized one. Traumatic penetration of the skin, and I culture the lesion to determine what's going on. Because of the fact that the toxin is produced locally, it does not disseminate to the blood, and so this is rarely a fatal condition. But remember, in addition to that toxin, which is a 3-component toxin that we talked about before, the organism also has a polypeptide capsule, which is immunogenic but protects against phagocytosis. Cipro, doxycycline, drugs of choice. If I'm speaking about a patient who had a similar exposure, but now inhaled the spores, realize that what's happening is that I'm going to develop a often fatal hemorrhagic mediastinal lymphadenitis due to the fact that I'm delivering the spores into the very sensitive, oxygenated, and easily blood supplied materials in the lung. So the fact that the organism now germinates in that very favorable environment and makes the toxin means that these are the ones that we worry about weaponization with. So very acute onset, rapidly fatal. Remember, one of the key clues is mediastinal widening. Remember that normally the silhouette of the heart should be less than half of the value of the distance between the two sides of the rib cage on a radiograph. If I have more than that space taken up by the shadow of the heart inside the mediastinum, then I have got a problem. They still do sometimes mention postal workers because of our concern about bioweaponization. People exposed to a white powdery substance always strikes fear in the hearts of our care workers. The anthrax toxin, remember, I've said several times, a 3-component toxin, the only one we'll talk about. It is heat labile, so easily destroyed by temperature. The B component, remember it's an AAB toxin. The B component is called the protective antigen. And the A components, which there are 2, one is an edema factor, which acts as an adenylate cyclase toxin. The second one, the lethal factor, directly kills cells. Now, again, Cipro, Doxy work, but the problem in the case of pulmonary anthrax is that one has to work very rapidly, because remember, it's the toxin being produced that kills you. So even killing the organisms may not be enough to save you from the toxin that has already been made. There is a vaccine that was made by the military in cases of our worries of bioweaponization. In the past, special vaccines used in specific populations, like the military, have not been asked, but there is one. Bacillus cereus, as I said, very rapid onset of vomiting after a meal. There are only 2 things that will do this. Staph aureus, if it's salty foods you ate at a picnic. B. cereus, if it's rice dishes. And you can get that from the species name. Cereus, cereal, from the Latin, okay? So cereal types of foods, rice dishes. The emetic toxin is preformed, and that's why it's so rapid. There is a diarrheal toxin that can be made in vivo if there is an infection that is going to occur. That one onsets around 18 hours, and it's one that is a cyclic AMP inducer. Now, while I'm on the subject of some diarrheal and vomiting agents, in my opinion, the way you should manage the memorization of this topic is to think about the fact that I've got 2 agents that will start me vomiting very rapidly. And I've spoken about them multiple times, Staph aureus and B. cereus. Then there is a very wide number of organisms that will start you vomiting within 8 hours to 24 hours of a meal. And there are so many of those that I truly think that memorizing minor differences within those time frames is not going to be helpful to you. So as you'll see as we complete the diarrheal agents, I'll say to you that I organize them, first of all, by whether or not the onset is very rapid. If it's very rapid, I know it's caused by a toxin. It's a toxicosis. And then if it's less rapid, I will subdivide them according to whether or not the diarrhea is watery or bloody, because that tells me whether the organism is causing the diarrhea by a toxin, if it's watery, or via invasion of the bowel wall, if it's bloody. So that's the little mental algorithm I make for myself as I'm trying to divide them. But this very early onset is very important because it divides these 2 from anything else. And like the diarrhea and vomiting associated with Staph aureus, notice no drugs recommended, supportive care only. Our anaerobic spore former, Clostridium, is also very persistent in the soil because of the spore form. And so remember, when it is introduced into the body, either by traumatic implantation, in the case of tetani or perfringens or botulinum, realize that it needs to be associated with a puncture wound or a wound where there has been significant loss of blood supply, because this is an anaerobe. Therefore, exposure to oxygen in the blood will indeed kill it, okay? Now, the foodborne one is botulinum, and we'll talk about several types of that. And the one that is a normal flora in the colon is C. difficile, which also happens to be the number one nosocomial antibiotic-associated diarrhea. So looking at our patients here, realize if the presenting complaint is muscle spasms, then I would be thinking in this group of tetanus. And remember, they're going to have to suggest to you that this is an unvaccinated individual. So this is unbelievably rare in the United States. It would be a dirty puncture wound. And honestly, this is so rare that I doubt that they would expect you to identify a case of trismus, which is lockjaw, the paralysis of the facial muscles, rhizus sardonicus, which is the rigid facial grin of the person with this problem. Opisthotonus refers to the fact that the patient, if laying on their back, would touch the ground only at the back of their head and their heels. So all of these are manifestations of the action of the toxin known as tetanospasmin, which is going to block the inhibitory transmitters, glycine and GABA. So the problem is that any muscle contraction becomes unopposed. It's a rigid paralysis, okay? Now, therapy, very difficult, long-term, but we have hyperimmune globulin that we can give, metronidazole to kill any residual organisms because it's anaerobic, and then remember the vaccine, which is very effective and repeated at 10-year intervals, is a toxoid that is contained in the DTAP, the Tdap, and so forth. Now, in my opinion, their best route of questioning on this organism is that of wound management. Because unlike the diagnosis and therapy of actual tetanus, which is unbelievably rare in the United States, wound management is a daily occurrence in emergency departments worldwide. So realize that my first decision when I'm confronted with a wound is to evaluate the wound itself. Is it a clean, fresh, relatively recent wound? Or is it a wound that happened some time ago and has been contaminated with saliva or soil and has some aspect of lost blood supply, either a deep puncture or a crushing injury? If I start off with the clean, fresh, new wound, then remember that my next question is going to be about the vaccine status of the patient. If they have completed their primary vaccine series and the last booster was in the last 10 years, then I can simply leave them alone other than cleaning the wound as best I can and sending them home. Okay? They do not need a repeated vaccination. They do not need antibiotics. They will be fine. If I do not know what the patient's vaccination status is, or they have not completed their primary series, I would vaccinate them. And if their most recent booster was more than 10 years ago, then I'm going to vaccinate them as well. Okay? The reason for repeating these vaccines at 10-year intervals, if you recall, is because that is the lifespan of the B lymphocyte memory cell. Okay? Now, if I have anything that is more complicated, either by age or by dirt or by crushing injury, then again, when I ask about the vaccination series, if they have completed their vaccination series and their most recent booster was within the past 5 years, then I'm going to say they're fine. I'm still going to clean out the wound as best I can, but they have a memory against the toxin, and therefore they will not need further therapy. If it's been more than 5 years since their last booster, they should receive a vaccine booster. And if I don't know what their vaccination status is, remember, I'm going to both vaccinate and give them tetanus immune globulin. Okay? All right. Now, as we look at botulism, remember, this is going to present as a descending flaccid paralysis. Now, again, we do not see botulism very commonly in the United States, but the most common of the forms is infantile botulism because the child has an intestinal pH, which is very alkaline compared to the adult. Once you develop your normal flora, you then become refractory to the germination of the spores. But in the case of infants with a very alkaline pH, the organism can burst out of its spore coat and begin to grow in the intestine. So realize this is the only form that is actually an infection and not a toxicosis. Okay? So it would be an infant less than 1 year of age. The mention of honey in feeding is because honey is sticky, and so it can pick up the spores from the environment and transmit them to the child. I actually don't believe that the spores survive in honey, but that is a point that's up for argument. Some people say it is, if the honey is raw honey. But as a point of fact, honey is a pretty unbelievable semi-solid that we don't understand a lot about. And if you think about it, you can put even raw honey in a cabinet in your kitchen, and it will keep forever. So bees are producing this material with some sort of antibacterial effect in it. And I sincerely doubt that it would have living spores inside it. But that's sort of not arguable, okay? If they mention honey, then we're suspecting this to be a problem. Now, the toxin blocks acetylcholine release. So remember, it's going to be absorbed by the gut, carried via the blood to the peripheral nerve, and as a result, I'm going to get a flaccid paralysis. Okay? This is called sometimes floppy baby syndrome. Okay? Now, treatment, antitoxin, and penicillin G because it's an infection. The foodborne form of botulism, very rare, but remember it would be associated with home canned vegetables. When I say alkaline vegetables, I basically mean anything except tomatoes. Tomatoes are very acidic, but home canned alkaline vegetables, actually a more common source nowadays, is from smoked fish preparations that are produced in a vacuum-packed sort of presentation. Those have been shown sometimes to have the spores, to have the toxin in them. But this is a toxicosis, as you notice. So what is ingested is the preformed toxin, and the prevention is actually quite simple. It simply involves heating the food over 60 degrees centigrade when you get it out of whatever packaging it comes in. Wound botulism is the most rare of the three, but again, This would be an implantation of the spores into a wound, and the symptoms would not involve the gastrointestinal tract because it's going to be spread into the contiguous tissues around the wound and not into the GI tract or being produced there. Again, treatment would be antitoxin and penicillin. Gas gangrene is the presentation of C. perfringens, a wound that develops into a flesh-eating, destructive, myonecrotic material. Remember, anytime I have an anaerobe in a location, they don't smell good. So mention of foul-smelling wound dressings or whatever. This progresses very, very rapidly because of the large number of toxins the organism produces. The major one is called the alpha toxin. It's a lecithinase, but do remember there are dozens of other ones involved as well. And so the key clues with gas gangrene are going to be my tremendously rapid spread, the liquefaction of tissues, the hepatic toxicity, and the production of gas so that the tissue, when pressed, will exhibit crepitus. You will be able to hear the gas extending through the fascial planes. The Naegler reaction is sometimes mentioned as a diagnostic. It is a test to allow you to identify the presence of the alpha toxin, and basically it's an immune complex reaction. So what you do is grow the testing organisms on a petri dish. You then take half of the petri dish and apply antibodies to the toxin, and if you get deposits of immune complexes between the toxin and the antitoxin, you've established that the alpha toxin is being made. So not only have you identified the organism, but you've identified the specific toxin that it's making. Clindamycin, penicillin, and incredible amounts of debridement have to be done. Remember, that often involves amputation because the organism is actually well beyond the point where you're seeing tissue damage visually. So I have to amputate well above the leading edge of where I'm seeing manifestations. There have been some successes by hyperbaric oxygen chambers, forcing oxygen into the area. Keep in mind, it's an anaerobe, so oxygen will kill it. C. perfringens diarrhea is a watery one, so again, a toxicosis. But remember, this often comes from reheated meat dishes, and they have a tendency to use as a clue reheated Mexican food, not because it's particularly associated with that type of food necessarily, but I think most Mexican restaurants will give you a large amount of food, and people end up taking it home and then not reheating it properly. So remember, these are all susceptible to heat, and if you simply reheat food that you take home, you can be protected from these. The onset time would be in that middle range that I told you I wouldn't worry about. It's certainly not rapid, and it's certainly not extremely slow, so somewhere between that 12-18 hour time after the reheating of the Mexican meal. Clostridium difficile is our final one, and as we said, this is the one that is the #1 cause of nosocomial antibiotic-associated diarrhea. So this is going to be a patient who has been on antibiotics for 1 week or longer. It's a pseudomembranous diarrhea, which really doesn't need to be mentioned, but it's a normal flora organism who overgrows when you wipe out the competing flora. So it has 2 toxins. Toxin A is an enterotoxin, and toxin B is cytopathic. Treatment I had to change the recommendation here based on what the AMA is now saying. As you might imagine, I have a lot of insecurity about making vancomycin a first choice, but this has become enough of a problem with drug resistance that they are now recommending vancomycin as the choice in this case. If at all possible, it would be best to remove the patient from antibiotics altogether and hopefully allow them to regenerate their normal flora. Metronidazole, often it is resistant to that. You need to isolate the patient, and remember, any bedpan or bathroom material needs to be sanitized well because it's a spore former. As we move into the non-spore formers, okay, starting with our aerobes, we have Corynebacterium diphtheriae, which, as I said, would not occur in a vaccinated individual in the United States. So that's going to be a key clue. And there are pockets of people in the United States who don't vaccinate for varieties of reasons. Not any of them good ones, generally, but we have normal flora organisms, if you recall, that are in this category. We refer to them as diphtheroids, and the difference between a diphtheroid and the pathogen is that the diphtheroid is infected with a phage that actually is encoding the production of the toxin. Now, of course, I can't see the difference between those two just by visual gram stain. So what that means is that my diagnostic test is going to have to involve identifying the production of the toxin. This is one of those cases in the loved CBS mnemonic that I gave you, that you have a lysogenized organism that then begins to produce the toxin. It's generally transmitted via respiratory droplets, and it can be either the phage or the bacterium that is lysogenized transmitted. The patient will present with sore throat and fever and cough. Remember the clue of the child being unvaccinated. And then, very important to recognize this very dense gray pseudomembrane that will form in the oropharynx and will bleed profusely when disturbed. Realize this is the only oropharyngeal membrane that will do that. So that is an important clue. If you hit it with a tongue depressor and dislodge it, you can actually have the mouth fill up with blood very rapidly, and as a result, your child can asphyxiate. So one has to be very careful. Remember, gray to black colonies will grow on tellurite agar. The ELEC test is the test to identify the toxin, and again, it's simply a test that allows me to distinguish the organism that is producing the toxin and the antitoxin that works against it. So again, it's a precipitation of immune complexes that I'm detecting. The toxin is an ADP ribosylator of eukaryotic elongation factor 2. Remember, the binding component attaches to heart, nerve, and epithelial cells. The organism does not invade, but the toxin becomes bloodborne. So remember that over time, I will have a large number of other potential manifestations, up to and including myocarditis, because of the attachment to these cells, which are not in the immediate area of where the organism is. Treat with erythromycin and antitoxin. For the endocarditis, I have to move up to penicillin and aminoglycosides. And remember, perfectly good vaccine that contains the toxoid boosters every 10 years to produce more memory cells. Listeria is our first facultative intracellular. So we'll get a chance to review the immune response here in a moment. But this one is found in nature, widespread in animal GI and GU tracts. So the most common port of exposure is in foods that are kept in chilled refrigerated cases that are from dairy or meat sources. We call this cold enrichment because this organism actually prefers cool temperatures to grow and will grow faster in the cold than others. It is a problem in my immunocompromised patients, in pregnant women who you will recall are also immunocompromised. I can get transplacental transmission. And remember, finally, it's the number one cause of septicemia and meningitis in my cancer and kidney transplant patients. So, as a meningitis and septicemia, remember fever, hypotension, tachycardia. The patient is going to grow gram-positive rods that are motile via cold enrichment. Notice I'm not going to emphasize much about the motility, although it is almost always mentioned in books, because the key with listeria, if you keep your focus on the mechanism of pathogenesis, you would realize that inside the body, it's going to be inside my mononuclear phagocytes. Well, if it's inside one of my cells, the motility is not terribly key to the direct pathogenesis. But remember, if I say facultative intracellular to you, this should immediately take you into the pathway of the nirvana diagram that goes APC1 to TH1 and then back to the APC1 through stimulation with interferon gamma. So remember, this is a classic granulomatous inflammatory response, and that is the mechanism that I would see in the patient. Now, if this infects a neonate, realize that this would be a granulomatous septicemia, very high mortality. The condition is called granulomatosis infantisepticum, and that typically is acquired by transmission across the placenta. Okay? Now, in the case of the neonatal septicemia, for which it is the number 3 cause, realize that will be 3 to 4 weeks after birth. As I said, both GBS and E. coli would be more acutely after birth than this would. But again, that takes me right back to the concept of what is causing the problem here. These interactions take time to develop, so it really shouldn't surprise you that this presentation will take more time than a simple neutrophil response to an extracellular bacterium, which would be the case in the other 2 forms. This one, typically acquired during parturition, and again, treatment ampicillin and gentamicin for all of these. If I know a pregnant woman is eating dairy foods, then I should be concerned best to avoid any sort of delicatessen food during pregnancy, just because you can't predict for certain. My gram-positive anaerobic filamentous bacilli, I have actinomyces, which is a normal flora organism in locations of my body that are anaerobic. And realize we're aerobic creatures, so there aren't really a lot of these in our bodies. But the gingival crevices around the teeth, portions of the abdomen and the female reproductive tract. And so where I will see problems is where the organism spreads from those locations. So this is going to be one of those diseases where I think location of lesion being very prominent in what I decide. In most cases, I'm going to have subcutaneous swelling and abscess formation onto the surface of the skin, particularly from places where I would anticipate anaerobic foci could exist. So from the jawline outwards, we call that lumpy jaw. Pelvic disease associated with IUDs that have been left in for too long or had contamination from the anaerobic sites. If I have bowel trauma, I can have this getting into areas where it will produce lesions in following surgery or trauma. And remember that the classic description of an actinomycotic lesion is of a mycetoma. What a mycetoma is simply an abscess that is draining yellow granular pus out of multiple sinus tracts. And that would be true in a variety of different things. So remember, if they were to describe such a lesion, you're going to think in this case location, whether or not it is near an anaerobic focus. You're going to culture the pus, and in this case, of course, you'd find anaerobic filamentous gram-positive bacteria. Because it's an anaerobe, it's going to invade anytime I have diminished oxygenation, and the therapy is generally quite a bit of debridement, surgical drainage, and then therapy with ampicillin or penicillin G. For my gram-positive aerobic and filamentous bacteria, I have another mycetoma agent. Nocardia comes in two forms, Asteroides and Brasiliensis. Both are found in the soil and in dust worldwide. So I can either inhale them and develop the problem, or I can have them traumatically implanted. In the case of the inhalation, it is most commonly Nocardia asteroides that causes the problem. In the case of the subcutaneous swelling, it's more typically Brasiliensis. So this one, Nocardia asteroides, would be most common, and this one, Nocardia brasiliensis. So now, a immunocompromised patient who inhales Nocardia is going to develop an acute or subacute pneumonia. You're going to develop cavitary lesions and abscesses and pleural effusion. It can spread via the blood to the central nervous system, and it is going to culture out as a branching, beaded filamentous gram-positive bacillus, which is weakly acid-fast. Now remember that the difference between nocardia as a cause of problems in the lung and so forth is going to also be associated with the fact that it prefers aerobic environments. So I would find nocardia lesions in a very different tissue location than I would find actinomyces. Any sort of immunosuppression, cancer patients are predisposed, clearly because T-cell immunity is very important. It is a facultative intracellular, so it would use that same pathway of the Th1 being spoken to by the APC1 and then delivering interferon gamma to cause the activation of granuloma formation. Now, when I have subcutaneous lesions, these again are an example of a non-mycotic mycetoma. So realize when I say non-mycotic, I am distinguishing these from the other forms of mycetomas, which are in the fungal chapter, things like sporothrix. So these are simply the bacterial versions of mycetoma formers, and this would be much more common in Central and South America, but some of these cases do occur in the southern U.S. as well. And the problem is that the organisms have been traumatically implanted. So To tell this mycetoma from another, remember that this is aerobic, a weakly acid-fast organism that would be cultured out of the pus, but otherwise the lesions themselves might look quite similar. These would be found on the skin primarily, whereas actinomyces is going to come from inside the body and erupt outward. So here we are at the end of what I have categorized as the gram-positive rods, but I want you to remember that Mycobacterium doesn't gram stain. So I did this in order to put it up front with the more important organisms in the organization. But it is an acid-fast organism, and it's worth commenting for a moment on what has been happening as we've been going page by page through the gram-positive rods. If I started at the very beginning of this section and spoke about the standard garden variety gram-positive rod, like Corynebacterium, for example, it would be true that most of those organisms have about 30 carbons in the fatty acids that are found in their envelope. That's about standard. As we moved up to Nocardia, which we finished just a moment ago, you would find that Nocardia had about 50 carbons in the fatty acids in its envelope, which was why I said to you that Nocardia is partially acid-fast. As we move into the mycobacterial group, now we have 90 carbon length fatty acids. So this is what's making the organism so waxy on its surface. And we refer to these very long carbon chain fatty acids as mycolic acids, and they are unique to this group. Okay, so the acid fastness goes with the number of carbons in the chains of the fatty acids, although you certainly don't have to memorize those numbers. Now, as we look at Mycobacterium, this is a tremendous pathogen worldwide, needless to say. In the United States, we do not have a lot of cases, 2.8 per 100,000, but it would be associated with cases of low socioeconomic status and crowding and poverty. It is the most common infectious disease cause of death worldwide, and it's transmitted by respiratory droplets with nuclear size about 5 microns or less. But because of that waxy coat, it's very resistant to drying and disinfectants, sensitive to ultraviolet light. Now, the envelope of Mycobacterium is unique and worth spending some time on, but realize, as I said, the key issue here for my categorizing it as a gram-positive was the fact that it has no outer membrane. So it is more closely associated with a gram-positive anatomy than it is with a gram-negative. Its outermost surface has these very long chain fatty acids and waxes and mycosides and something called cord factor. And I'm going to talk about the role of each of those in the pathogenesis. But taken together, these make the organism very difficult to destroy, either with drugs or in the environment, or indeed inside the body. Cord factor has been shown to be the most strongly associated with pathogenesis, and I can say basically that the more cord factor an organism has, the more pathogenic that strain will be. There are porins through all of this wax, which serve in passive transport. Then immediately under that, there is a layer of arabinogalactan, a very small amount of peptidoglycan, usually about a tri-layer, but significantly less than the normal gram-positive. And then, of course, we have the cytoplasmic membrane, just as we would in any other organism. When we speak about tuberculosis, Realize generally this is acquired in early childhood and is asymptomatic. And so what we see at the point that the patient becomes symptomatic is usually the reactivational form of the disease. So typically in a young child, they would become infected in their youth. They would apparently resolve the infection, but because of the fact that the organism is so hard to kill, you would continue to have functional bacilli inside the granulomas in the lung. So when there is any waning of the immune response, then what I develop is going to be reactivational disease in an adult setting. Okay, so at the first point of symptoms, I'm going to have weight loss, cough, fatigue, night sweats, and again, those would be attributed to the production of interleukin-1. And remember, because this is not endemic in the United States, they're going to need to give you a geographic clue that would tell you that this person is in an area of endemicity or that they are in a location in the United States where it is a possibility. The initial symptoms, if there are any, are going to develop 2 months after exposure because the patient has now gone through all of the early stages. They now have an immune response against the organism that is walling them off in the nodes of the mediastinum. So I'm going to see mediastinal lymphadenopathy. Initially, I refer to it as the Ghone focus when I've got lesions in the base of the lung, and as it associates with mediastinal nodes, it's then referred to as a Ghone complex. The tuberculin test should be positive in this patient. Okay? When we speak about what's going on, this is the classic demonstration of the facultative intracellular response to the immunity. So realize, because of the fact that this organism is so difficult to kill, I'm going to develop granulomas, which in their center are going to caseate. Okay, that cheesy material, friable in the center, still has functional bacilli inside it, although it's the body's attempt to wall off the pathogen in these granulomas and prevent them from spreading elsewhere. Cord factor, also known as trehalose dimycolate, is going to be the most associated with virulence. It inhibits diapedesis. It disrupts mitochondrial respiration. Lipoarabinomannan is the material that inhibits macrophage activation by interferon gamma and induces secretion of the tumor necrosis factor alpha, which is what's responsible for the cachexia and weight loss. Sulfatides are molecules elaborated by the organism, which are sulfolipids, and when they are hydrolyzed inside the phagocytic cell, they produce sulfuric acid. So the organism seems to instruct the macrophage not to add on the lysosomal contents, and it lives quite happily inside the phagosome without lysosomal fusion. Finally, mycobactin is the molecule made by the organism that acts as a siderophore. And we've talked about that before, the competition between microbes and man for the bioavailable forms of iron has been since the dawn of time. Now, as we talk about reactivational disease, realize that a bloody sputum is going to be one of the key signs other than the cough and hemoptysis. The cough and night sweats. Realize that in this case, this person is going to have a history of prior exposure and probably treatment, and then some sort of debilitating event in their life which has caused them to be homeless or incarcerated or whatever. The reactivational form is going to occur in the apices of the lung, because remember, these people have an underlying immune response. So the organism will actually go to the apex of the lung, where by definition I have less oxygen, but they're trying to stay away from the perfusion at the apex, because the immune cells would come in areas of high perfusion. So this is one of those things where the VQ mismatch moves them from the base of the lung when they have the first infection and no immune response there, to the apices in order to flee what little immune response the patient is making. Of course, I'm going to X-ray. I would have a positive tuberculin test. I would find acid-fast bacilli in the sputum, perhaps, but realize a much more rapid test is now used. It's a fluorescent dye test with auramine, rhodamine. You simply take that fluorescent dye, add it to a sputum sample, and if you get fluorescence, that tells you you have to follow up with an acid-fast stain. It's also the only mycobacterium which produces niacin, so that is also a very rapid test. And of course, we have nucleic acid amplification tests as well. But the reason why I don't tend to emphasize those as much as you might expect me to is because remember, when you're preparing for your exam, if they were to mention the nucleic acid amplification test, you have to remember that they're going to have to tell you which one. So it would become a less challenging question from their perspective if they said nucleic acid amplification testing for Mycobacterium tuberculosis was positive. You know the answer to the diagnosis, and they would prefer not to do that, of course, because it makes the question less challenging. Realize that the disease can disseminate in the immunocompromised. We refer to this as miliary TB, which will spread to virtually any oxygen-rich area of the body. The name miliary refers to the fact that it looks like little millet seeds, little seeds of grain like rice. And so I will see this in the meninges, I can see it in the bone, you name it, I can have spread to oxygen-rich areas. Now, when we talk about therapy for TB, realize we've been doing this for so long that we have a huge amount of drug resistance. So the current protocol is to start with 2 months of isoniazid plus rifampin, pyrazinamide, then follow that by 4 months with isoniazid and rifampin. So long-term therapy. If I have drug resistance, then I need to add either ethambutol or streptomycin. And multi-drug resistant TB, which is very scary, needless to say, is now being treated with betaquiline, which is a diarylquinolone. It has a different mechanism of action than any of the other drugs we've used before. So we're hoping that the organism doesn't become resistant to it as well. But the problem of long-term treatment always does tend to encourage organisms to develop resistances to avoid. Prophylaxis, isoniazid for 9 months in persons who have been exposed. Many places globally use the BCG vaccine, which is a live attenuated vaccine. But remember, we do not use this in the United States. It prevents dissemination, but not pulmonary disease. So we do not use it because it gives the false positive on the TB test. And because we do not have the organism endemic, we don't want to lose the possibility of using that screening test the way we do in the United States. The natural history of this disease with concurrent HIV infection, remember the progression is 10% per each year. The lesions will return to the base of the lung in this case, because remember, when they move to the apices, they're trying to avoid the perfusion bringing in the immune cells. There's less perfusion in the apex, so they're happier there. Once the immune response has diminished in HIV, doesn't matter how much perfusion there is because there isn't any immunity. So they return in their lesions to the base of the lung. In any other cases, the progression from latency occurs at a rate of 5% in 2 years, and those lesions, as we said, are in the apex. Diagnosis, the auramine-rhodamine stain. This is not an immunofluorescent stain, so it's not antibody bound. It's very sensitive, but not specific. Nocardia will also turn positive. So I use it to rule out, okay? If I get a negative on the auramine-rhodamine, I know I can say that the patient does not have TB. If I get a positive, then I have to confirm with acid fast. It is a niacin producer. Remember that the quantiferon test, or interferon gamma release assay, is one that is supplanting the tuberculin test because it has the advantage that you don't have to get the patient back to read the results. Okay? For the tuberculin test, which is pretty standard and is a great question because it demonstrates the principles of the APC1, TH1, interferon gamma producing the stimulation of the APC1. The tuberculin test, I have to come back in 48 to 72 hours to have it read. And the result is determined to be positive at different levels in different patients, depending on their level of immunity. Anything greater than 5 millimeters is considered positive in an AIDS patient. Greater than 10 millimeters in one of our high-risk groups, like IV drug users, positive healthcare workers, etc., and greater than 15 millimeters diameter in the general population. So realize we're looking at induration. Once again, might as well belabor this to make sure you feel comfortable. This is the APC1 stimulating the T helper 1, which in turn then makes interferon gamma, which calls in more APC1s and activates them. So what I'm getting is infiltration of these activated cells in a sort of round robin. So it is not erythema, it's induration. I've got infiltrating cells. Now, since I have that drawn out now, realize that when I look for interferon gamma release, all I have to do is take a sample of blood from a person I want to test and measure the production of interferon gamma when I stimulate the culture with tuberculin. So it's simply an in vitro assay that allows me to demonstrate this same reaction. So this one is much more popular now because of the fact that I can do it quite quickly and not require people to come back. It's gaining application in the United States, but again, we don't have a lot of TB, so the tuberculin test, is still the normal screening test for pre-employment physicals and so forth. If I get a positive result, I want to do a chest X-ray. Mycobacterium leprae, pretty uncommon in the United States, fewer than 100 cases per year, but it's another one that illustrates a very nice point immunologically that I'll show to you. It's endemic in India, Myanmar, Nepal, Brazil, Tanzania. So they'll have to give you some sort of a travel history or immigration status. It's an obligate intracellular, meaning that we can't grow it, but it still lives inside macrophages. So once again, it's going to be the same old APC1, Th1, APC1 with interferon gamma in the case of the correct immune response to make. It's an obligate intracellular. Its incubation period can be decades long. The mean is 10 years for lepromatous and 4 years for tuberculoid. And the difference between those two forms, the tuberculoid and the lepromatous, is a classic demonstration of what happens when my APCs make the wrong choice. Now, we truly don't know why it is that your APC would send the wrong messaging downstream, but I think you can predict why these two forms of disease would look so different when you notice that the tuberculoid form has a very strong activation of that classical APC, turning on a T helper 1, making interleukin 12, and then causing the destruction of the organisms in the tissues. If you remember that the organisms are inside the macrophages of nerves and skin, you realize that the presenting complaint is going to be macules of cellular infiltration on the skin usually that have lowered sensitivity to touch and pain and are hypopigmented. Okay? Typically going to be the cooler areas of the skin because the organism prefers cooler skin. And in this case, because of the fact it's the classic do loop between the M1 and the TH1, the analogy to the tuberculin test, the lepromin test, is going to be positive. I can find acid-fast bacilli inside a punch biopsy, but I won't find many of them. So it's often described as being pauci bacillary. The reason being, I'm making the right immune response. Now look what happens when I make the wrong immune response. The lepromatous form of the disease, patient develops a weak cell-mediated immune response because they go down the right-hand side of nirvana from M2 to Th2, interleukin 4 production, and antibody synthesis. Well, this is an organism hiding inside macrophages, so that's not going to do me any good. So in this case, the damage that causes death of nerve cells is from the overgrowth of the bacteria, not from the immune response. In the case of tuberculoid, the damage is actually due to the immune response. I have lesser amounts of spread, but I have damage that causes hypoesthesia. Now, realize the number of lesions is going to be dramatically more in a lepromatous patient because the organism is basically proliferating undeterred inside the body. So again, endemic area, a negative lepromin test in this scenario, but many bacilli found inside the punch biopsy or nasal scrapings. Okay, I require multiple drug therapy for both of these, dapsone and rifampicin for the tuberculoid form, add on clofazimine for the lepromatous form. And our final group of the gram-positive bacilli are the atypical mycobacteria, or the mycobacteria other than tuberculosis, the MOTS, okay? Now, these are quite common. I think much more likely to show up on your exam, in fact, than Mycobacterium leprae, although, as I said, it makes for a good immuno question, which is why we did it. But in the case of the MOTS, remember, all of these are problems in my AIDS patients. And AIDS is a predisposing condition in huge numbers of questions on your exam. Now, what makes them unusual? They're not transmissible human to human. They're found in point sources of soil and water. As I said, problems in our immunocompromised. And we distinguish between them on the basis of their production of yellow-orange or carotenoid pigments. We say that they are non-chromogens when they don't produce these pigments. We call them photochromogens when they make the pigments after exposure to light. And we call them scotochromogens when they make the pigment in the dark. So if you look at who would be anticipated to have problems, my AIDS patients are typically going to present with disseminated infections in the lung, etc. So chronic cough, bloody sputum, fatigue, malaise, weight loss. They may also have gastrointestinal signs. And the two causal species are Kansasi, which is a photochromogen, and Avium intracellulare, which is a non-chromogen. Now, notice over here on my treatment commentary, there is a level of standard prophylaxis against these in AIDS. At 50 CD4 cells and fewer, I begin standard prophylaxis with a macrolide plus ethambutol. That basically says the immune response is gone at that point, which is why we do not see these in persons with normal immunity. A condition on the skin of persons who grow tropical fish in their home. This is referred to as fish tank granuloma. I hope you're not surprised that this is a granulomatous condition. So typically it's on the hands of people who are mentioned to grow tropical fish. I treat it with isoniazid, rifampin, or ethambutol. And then finally, a child who has a single lymph node enlargement, usually cervical lymph node, with granulomas found inside, would be a child who has Mycobacterium scrofulaceum. So the species here is scrofulaceum. Okay, now all of these are going to be granuloma formers. In the case of scrofulaceum, what I'm going to do is surgery, both to make the diagnosis and to cure the problem. I should mention the name of the fish tank granuloma agent is Mycobacterium marinum. Okay, and that one, if you're talking about things that need to be distinguished from one another on the basis of them causing ulcerating lesions on the skin, think when we get into the gram-negative rods of Vibrio vulnificus, which could occur on the hands of people who either occupationally or recreationally open oysters and accidentally cut their skin. So remember, already I said to you, Vibrio is an organism that has a predisposition to liking alkaline water sources. So lots of contamination. That mentioned the difference between a fish tank, which is normally freshwater fish, and Vibrio, which is going to be a saltwater source because of the pH. But again, they may superficially look similar. Hand lesions that are ulcerating. This one is going to be an abscess, of course, because Vibrio is extracellular. This one is going to be a granuloma, okay? But lots of ways to tell them apart. That's a good place to stop because our next topic, when we come back, will be gram-negative cocci, which are a small group, but we're making progress through this painful chapter, and I hope you're still with me.